Hello, everyone. We're here live at PSTM 22 in Boston for a live recording of PRS Global Open Deep Cuts podcast. I'm Puru Nagarkar. We're here with Dr. Kyle Eberlin. Dr. Kyle Eberlin is an associate professor of surgery at the Massachusetts General Hospital, as well as a program director of the Mass General Brigham Harvard Plastic Surgery Residency Program, and the associate program director of the MGH Hand Surgery Fellowship. He was the 2018 plastic surgery visiting professor for the American Society for Surgery of the Hand, and the 2020 Traveling Fellow for the American Society for the Peripheral Nerve. He's on the board of directors for ASPS and for the American Association for Hand Surgery, and on the editorial boards of PRS and PRS Global Open. Dr. Eberlin, welcome to Leveling Up.
Thanks a lot. I'm excited to be here.
Well, it's great to have you, and it's great to be doing this live production of this thing, which is the first time we're doing it, so it's new for all of us. Well, as you know, I talk with your residents and fellows to prepare for our interview, to kind of learn more about your styles and techniques. And this was very interesting, but to a man and woman, they all mentioned that you teach them a lot about surgery, but more importantly, about a lot of other skills. So, and this is something we've been talking about for the last 10 minutes while we've been sitting here, but they all mentioned your emphasis on time management. And I know you're a prolific researcher, you're clinically very busy, you've got a young family, so I feel like I really need to hear this from you. How do you do it? How do you manage your time? What are your management pearls that you've got up your sleeve? What are your principles for getting this done?
Well, thanks for the question. Being a surgeon, we're all very busy. We have many demands on our time, and I think the only way to really achieve things, not only surgically but outside the domain of surgery, is to be well organized. And I think if one's organized, you can then package the different parts of your life into these different buckets and do them at different times of the day. So, for instance, the thing that works well in my life is I'm a very early riser. I'm up before my family is, and a lot of the academic things that I do happen really in the wee hours of the morning, before many of my residents are even in the hospital. So I think that element in doing things kind of at night or early in the morning, I think is really important. And it's hard to say that, and it's hard to do it, truthfully, but I think that combined with good organizational skills to really maximize your time inside and outside the hospital professionally, I think is very important.
Yeah. Well, how do you organize your time to be able to do that effectively? What are kind of the, this is one of the things that always gets to me is that I have emails piling up during the day. I'm doing my surgeries, and then at the end of the day, I'm looking at my email. I've got 20 emails and 15 texts, and there's 20 patient phone calls that I need to get to, and it's just a lot, right? And what should residents be looking at when they're looking at their life and schedule and saying, how do I manage this?
Well, I think everyone has to have their own system. And my system is that I try not to go to bed without answered emails, because if you don't do it one day, they're just going to pile up and you're just going to be behind the eight ball. But one of the things I found most effective is I have a to-do list that is it's a Microsoft Word document. I update it every day, and it's saved with the date. And it has a list of things in terms of priority, just administratively. Research projects, it has a list of those things. And it allows me to really calibrate my schedule to do that. And so I look every day, I wake up, I look at that list, what do I need to do? And some things stay on there for a while, and some things I check off quickly.
Yeah. You stay old school, Microsoft Word.
Yeah. Well, a funny story, I did it through Outlook, and I had a calendar link that I would use and update, and I lost it one time. And it was a real hassle to go back with IT and get all that back. So I said, I'm committed to doing it in the cloud, and I update it every day.
Nice. So I feel like this kind of connects with surgery, right? So you've got efficiency in life and time management. You've got efficiency in the operating room. And so multiple people also mentioned that you kind of have this way of self-assessing and kind of almost doing a debrief at the end of a difficult case or a complex case and saying, hey, what went well, what didn't go well, what took longer than it should. So what kinds of things have you learned about surgical efficiency by going through that process?
Well, I think being critical about every operation you do is important. And I say this to our residents and fellows all the time. I mean, you could be doing the most complicated neurotized free-functioning muscle transfer or a carpal tunnel release. There's always something that you can do better, even with the carpal tunnel release. Whether that's I took too long to set the patient up, or it took an extra 3 or 4 minutes. If you don't do that and you're not rigorous about it, you're not going to get better. So I think that's a critically important part of every operation. I actually spend time doing it and I'm glad the residents find it helpful, but I find it most helpful. And I love when they give me points and they say things that I didn't even think of, because that makes me better too.
Well, have you found that you've changed anything about the system that you're doing, or anything about your just, you were doing it one way and then you realized, hey, this is inefficient, and completely changed it based on that kind of an approach?
Yeah, I mean, one thing that's easy to articulate is, for instance, if you're doing a free flap, and there's a certain element of the free flap, which is I'm going to dissect the flap and do the debridement, dissect the flap. Then there's the microsurgical part, and then there's the inset part. Yeah. And I will ask our chief resident or fellow, tell me how long each of these parts is going to take. And I will write that on the board in the room. Yeah. And it's always an underestimation.
Of course.
It has to be. Yeah. But at least it holds people to it. And that way afterwards, you look at the board and you say, wow, this part took you twice as long as you thought. Why was that? Yeah. And that allows for self-reflection. So that is something that I like to do, but it makes things go much faster.
That's a really good idea. I have noticed that, I'm a hand surgeon too, and I've noticed that we've kind of got this inbuilt clock for us, right? Because we've got the tourniquet. And so you can say to yourself, oh yeah, carpal tunnel takes me 10 minutes. But then at the end of the case, you look and you're like, well, I'm going to write down 13 minutes on my up note, so I know that it didn't take me 10. So you kind of have this feedback that you're constantly getting, which you lose in free flaps though, because unless you're making that effort.
For sure. And even in a carpal tunnel release or a trigger finger release, I'll turn to the scrub tech and say, how long is this going to take me? And they'll say, oh, it's going to take you 6 minutes. I'm like, it's going to be 5. Yeah. So it gives you a little challenge as well.
Yeah. So, you're doing this for yourself and improving yourself, but what kinds of efficiency pitfalls do you find that even senior residents or fellows, people who are pretty far along, about to go out on their own, what kinds of pitfalls on efficiency do they tend to fall into?
Well, it's the natural learning curve of surgery, right? And if you watch a master surgeon, which I am not, but if you watch a master surgeon, every single spread, every single move is very demonstrative and achieves a lot with every single move. And so I think a lot of it comes with really critical observation of your own surgical skills and thinking about, what did I do that was a complete waste of time? How did I spin my wheels, and how do I do that better? And so I like to let residents and let fellows kind of go through that iterative process, because just watching someone do it faster is not that useful. Yeah. You have to kind of do it yourself and then have someone tell you how you could do it faster or better or more efficiently, to really improve.
I mean, I've definitely seen that where it is kind of hard. You finish the case, you say, well, that took a long time, but it's very hard to actually make that next step of assessment to say, why did it take a long time, without having someone else there to point it out to you.
And the person has to understand why it took longer than anticipated too, because a lot of times a junior trainee may not really understand what are the parts that could be made more efficient. Yeah.
Well, a lot of efficiency in complex cases, I think, comes down to setup, right? I mean, how have you set yourself up at the beginning, before the case ever started, to be efficient in the operating room?
Well, we all have our own way of doing it, but I like to, for instance, just use a free flap as an example. If the senior resident or fellow is dissecting the flap, before they do that, I'm going to say, tell me 10 steps that you're going to do to get this flap out. And it allows them to articulate it, and I can sort of see by talking to him or her whether they really understand what the hard part's going to be, and actually asking them, what are the hard parts going to be of this dissection? Yeah. And I can recall as a hand fellow, with very difficult cases at night, and we have, our fellows have autonomous privileges after a few months, but I remember as a fellow calling the senior staff member and saying, here's this case, here's what I'm going to do, but tell me the 2 things that I'm going to struggle with. And they would tell me that, and it was always correct.
Right. Yeah. It is predictable, and at the same time, until you've gone through it multiple times, it's hard to know when it's coming. Mm-hmm. So let's talk about free flaps. Let's talk about complex lower extremity and what you do in those kinds of cases to set yourself up for success. So, let's all the way back to indicating the case or, pre-op workup, coming up with your plan A, B, C. If you're looking at a complicated lower extremity, what kind of imaging are you using? Are you using CT angio? Are you using formal angio? How do you work these patients up?
I really like formal angiograms. I know it's a bit old school, but they're easy to get in my practice. And the reason I like them is it shows you the temporal sequence of inflow down into the foot for a lower extremity. And that's really valuable because it allows you to see perforator anatomy, but also see how robust and the caliber of each vessel. Yeah. So I like to have things planned to the centimeter. For instance, I'll say, if I'm doing a free flap to cover a knee, I know that the descending geniculate's usually 13 or 14 centimeters proximal to the knee. We'll measure that out. I'll draw a line on the thigh. That's where the pedicle is going to be, or that the inflow is going to be. So I think planning ahead of time is so valuable, and it saves you immense amount of time in the operating room.
Yeah, I mean that's going to speed you up a lot. You're not going to
sure.
be looking, wondering, is that it? Is that it?
Yeah.
You know exactly where it's going to be. So you don't like CT angio because you don't get that temporal effect.
They work very well. I know
Sure,
most people do use them, but it's easy enough for us to get angiograms,
Yeah.
so that's what we usually do.
What about flap choice? What's your go-to?
Most of the time we're doing ALTs if it's a fasciocutaneous flap. But truthfully, I'll ask the senior resident or fellow, what flap do you want to do and why?
Yeah.
And most of the time it's a reasonable thing. And sometimes they say, I want to do this flap because I haven't done it before. As long as it's appropriate for the patient, that's an okay thing to do.
Yeah, fair. One of the things that one of your residents mentioned, because this is something I get into a lot, which is when I'm doing lower extremity, ankle, posterior leg, foot, offloading is always a big problem. And so they mentioned that you like to use X-fixes a lot. Mm-hmm. Is that something you do routinely on every ankle or every foot?
Not always, but we do a lot of these with a really close collaboration with orthopedic surgery.
Yeah.
So they're involved to begin with, so it's very easy for them to put a kickstand external fixator on. And so my general gestalt is, if it's posterior, either Achilles or heel or even plantar foot, it's a good idea.
Yeah, that seems to make life much easier.
Yeah.
If you've got that. Yeah, I think I'm going to start doing that because it's always every time I've got that low, ankle, Achilles, flap, it's just such a pain to figure out how to offload it, and you're always worried that they're going to roll off and all of a sudden put pressure on that flap.
It doesn't take a lot to ruin it back there,
It
so
does not,
I like to keep it simple.
Yeah. What about, staying on that same kind of topic of setup for efficiency? Let's talk about replants. What are the kinds of things you do to set yourself up for success with those?
This is something I've thought about a lot because I think it's really important. And just like you guys, we do a really high volume of replantation surgery. And so what I learned, and I think most people learn early on, is if you're not efficient with it, you are going to hate it.
Yeah.
And there's nothing worse than 3:30 in the morning, you're trying to do the veins, it's bleeding everywhere, you're tired, it's hard. So I like to do everything possible to avoid that feeling.
Yeah.
And so I think more than half the operation can be done before the patient's even asleep in the operating room. So for instance, bringing the part up, dissecting it on the back table, K-wires in, having tenorrhaphy sutures in before the patient's even asleep, that is a real time saver. And the second thing is I like to do the veins first.
Okay.
And by doing the veins first, it's the hardest part of the case. It's arguably the most important from a perfusion perspective. And so I do that before even doing the arterial anastomosis, usually.
That's very interesting. So you set your part up on the back table, patient goes to sleep, slam the K-wires in, get the bone done, get the tendons done, flip, and do the veins.
Well, I'll do the extensor, so I'll do the osteosynthesis.
Yeah.
We'll do the extensor tendon repair. I'll do the venous anastomoses, and I'll close the dorsal skin provisionally.
Okay.
And then I'll flip volarly, do the rest of the structures.
Yeah.
And then usually at the end, you can listen to the dorsal side of the digit, and you can hear flow through the veins. And if you don't, you can always open it up.
So you do the veins with the tourniquet up?
Yes.
Because one of the things that people always talk about is, it's hard, you do the artery first and you open up the tourniquet, you see the veins because now they're bleeding, now you can see them, but you're like, no worries, we can find them, it's not a big problem.
That's correct. And I give full credit to Babak Safa from the Bunkie Clinic, who really he's a fantastic surgeon, great replantation surgeon, and he and I have shared a lot of thoughts about this. He's taught me a lot about it, and that's often the way he does it, and I found it to be very helpful. Yeah.
And that makes a lot of sense. Do the hard part first so that you're not doing the hardest part when you're the most tired.
Right.
At the end of the whole thing. Yeah. If you have multiple digits, are you doing the same kind of thing? You're batch processing, you're doing all the bones, all the extensor tendons, all the veins, and then maybe you run out of tourniquet at that point, perhaps, and then doing the artery and flexors?
Yeah, the only caveat is that if it's multi-digit injury, if you're planning to save all of them, that's what I do. But there are times where you're pretty sure you want to save two, and one's questionable. So I'll do the two that I'm really going to save, and then I'll kind of decide on the other one.
Come back to the third one.
Yeah. But usually when you do that, you're less inclined to do the third digit.
Right. I mean, you've kind of almost made the decision in advance.
Correct.
And it's clinical based on how the finger looks.
Right.
And, yeah.
And that comes with experience, but no one wants to waste time.
No.
And if you're not going to save the digit, you might as well decide that up front
Right.
to some degree.
Yeah, no, that makes a lot of sense. Something that was mentioned was tagging structures on the back table, and this always, becomes an issue. Is in that amputated digit that's been shredded by a table saw or a hedge trimmer or something like that. You tag the artery, you tag the nerve. They don't look that different from each other, and sometimes it can be hard to tell. So one of the things that someone mentioned was that you like to tag them with different kinds of suture, which I thought was a very clever idea.
Yeah, very often I'll take micro clips and then I'll take small clips, and the micro clips, for instance, might be on the nerve and the small clips may be on the artery. But I think it's very important to identify them, and not only to identify them, but to make it so that 3 hours from then you know where they are.
Yeah.
Because once you're in a situation one time where you're trying to find the artery, which you know where it is, but you can't find it.
See it. Yeah.
Again, those types of things drive me crazy, and I in those moments, I'm like, I'm not going to do that again.
Right. Well, and then that's the whole point of, that's where this whole podcast came from, is we've all got those moments of, oh, God, I'm never making that mistake again. But that's not important enough to write down in a textbook. That's never going to be in a textbook. It's always going to be School of Hard Knocks. So that's what we want to try and get at. So I feel like we've got these two parallel ideas that we've been talking about. One is kind of efficiency, and the other one is planning, right? So you talked about getting CT angios and using that to plan. And I was talking to one of your fellows yesterday, and he mentioned that you were really big into squash and really big into chess. And by the way, I wish I'd known this earlier because I've brought my squash shoes. But I feel that efficiency and foresight kind of fit really well into squash and chess. I mean, chess and foresight and planning, that's kind of obvious, and squash is kind of this super physical game where if you've got even a slight difference in skill level, the more efficient player is going to just kill the other one. I remember I was in college and I would be playing with a 70-year-old physics professor who couldn't barely walk because his knees were bad, but he'd mop the floor with me because he was just that efficient. How do you feel like what you learn from squash or chess help you inform your surgical skills or technique, or vice versa? Do you feel like you've learned anything from one to the other?
For sure, the answer is yes. As a brief plug for squash, because it's an amazing game, it has been deemed to be human chess because there's a lot of strategy involved with anticipation of where the other player is and where he or she is not going to be. So for sure there are many parallels. But I think that in particular for very complex extremity reconstruction, there are a lot of parallels with chess because you have to think ahead, you got to plan ahead, you got to think of all the different iterations of getting either down the road you want to be or getting off track.
Yeah.
So yeah, I think both inform each other. I would suggest that probably playing chess has made me a better surgeon more so than the reverse.
The reverse, yeah. That's fair. So, switching gears a little bit, someone mentioned to me that your philosophy with indicating patients for surgeries, that you want to explain to them their choices, but you want them to kind of ask you to do a specific surgery rather than trying to sell them something. And you do a lot of TMR and you do a lot of primary TMR, and you've done that, I think, in the last couple of years has become like a primary way of doing it. So I'm wondering how you talk to patients about TMR and how you kind of give them those choices and options.
Well, I think that type of preoperative counseling and shared decision-making is really germane to peripheral nerve surgery, not just TMR, but I do a lot of surgery for neuropathic pain, and many patients do very well, and some don't. And it's hard to have that crystal ball to know which one they're going to be. So I never want to oversell something ever to a patient. And if for a neuropathic pain situation, if the patient can live with it, they should not have surgery.
Yeah.
But if they can't live with it, then there are some things to talk about. And so I have found that to be immensely valuable and really critical because I want a happy patient and I want them to do well. And even my patients that I've done nerve operations on that may not have had a lot of benefit from surgery, many of them still are grateful that we tried and that, it's not like most of them are not unbelievably unhappy with me, and they said, look, we really tried, and we're going to move on to the next phase of your treatment.
Yeah. The neuropathic pain is hard because, like you said, you don't know who you're going to help and who you're not, and there's always going to be a subset of patients who just doesn't work, right?
Yeah.
But what about, when you talk about primary TMR, it's more preventative. They don't have that pain yet, but you're doing things because you know that so many patients do have pain, and you're going to stop them from having it. But that's kind of a very different conversation, right? Because it's hard. They don't have the problem yet. You're preventing it. How do you have that conversation with them?
Yeah, I actually think that the conversation about primary TMR is pretty easy because from a patient standpoint, it's really no different for them, right? I mean, if they're having an amputation for whatever reason, we're going to do this adjunctive measure at the time of amputation, and by the way, on the outside, it's going to look exactly the same, and it's probably going to help you. I think intellectually and academically, the hard part is deciding who are the right patients to receive it at the time of amputation. Because truthfully, not everyone should have it at the time of amputation. But I think a lot of people should, and some of our recent research has been kind of trying to figure out the sweet spot. Who are the right patients that have it at the time of amputation? Who are the right patients where we see how it goes, and if they develop pain or start to go down that pathway, then we offer it to them. But I think our inclination in our group is mostly to do it primarily if we can, and if it's safe for the patient.
Yeah. Who do you think are the wrong patients?
Well, I'm not sure there are wrong patients, and this is absolutely a matter of debate. But I think what I believe and what I think we've shown to some degree is that patients who are much older, whose nerves are not going to grow quickly, they may have a lot of systemic disease, and maybe their mortality, 5-year mortality, is pretty high. Those patients, it may not matter if they have TMR.
They may never develop the neuroma. They may never develop the pain.
Well, they will develop neuromas without doing something nerve ending, but they may not develop pain.
Right.
And so if you know someone's not going to develop pain for a lower extremity, then you shouldn't do it. I mean, do whatever you want with the nerves.
Right. It's extra surgery. Why go through
the Sure. And we're really careful in those patients not to over-dissect, not to increase their morbidity from an infectious or soft tissue healing perspective. I think that's really, really important. And that you learn that with time and experience, of course, when you take care of these patients. But
so what you're saying is there's a downside, which is you're potentially going to hurt vascularity because you're doing more dissection. And so if they've got poor tissue, poor vascularity to begin with, well, they've got a lower risk of developing painful neuroma and a higher risk of developing complications from the surgery.
Yeah, we're trying to thread the needle a little bit. And I think if you do it really carefully, you can avoid those complications. And truthfully, just thinking about the nerves is probably better than just doing your the standard tug of war like a lot of other surgeons do to do traction neurectomy.
Pull as much as you can, cut as proximal as you can. Do you talk with them about TMR versus RPNI? I mean, I know you've got this kind of combo hybrid thing that you do, right?
Yeah, I mean, I think what we know about the data is that both seem to work. There are more similarities, in my opinion, than there are differences. And to be frank, most patients are not going to really understand the nuances between the two. So it's not like I give them a choice, like, hey, for your tibial nerve, which one do you want? What do you? So usually not. But there are occasionally patients who come in who are very sophisticated, who come in with a stack of articles. Some of them are PRS Go articles because they can read them, where they're flipping through these papers in front of you, asking these questions. So that's a little different discussion.
Yeah, it's a very different conversation. Yeah. That is hard too because they're reading these papers, but maybe they don't understand them completely, right? Because let's face it, most surgeons probably don't understand these papers completely. So on the TMR topic, in the last couple of years, you've got this new clinic set up, right? The new system set up. Which seems like a really good, efficient way of getting primary TMRs done in kind of this combined clinic way. But tell me about how you set that up and what were the pain points along the way of getting that going if somebody else wanted to do that.
Yeah, no, it's a pretty interesting history because I was, if I rewind maybe 8 years, something like that, I was taking care of a lot of extremity injuries, doing lots of free flaps, and working pretty closely with one of my orthopedic trauma colleagues. And I would see patients, and I'd say, what did Dr. Heng think? And her name is Marilyn Heng. She's an amazing surgeon in person. But and she would say the same thing to the patients. What did Kyle say? So after all these back and forth discussions, calling her after clinic, we were like, why don't we just see the patients together?
Together, yeah.
Makes perfect sense. We're in clinic the same day. So we started doing that. And then, as TMR grew and as our clinic sort of expanded, that was conveniently the time when Ian Valerio, my good friend and partner, came to join MGH, and so it's grown. And one of the orthopedic oncology surgeons who does lots of amputations oncologically said, "Oh, this is great. We should." So it just sort of grew organically.
Yeah.
But I think to answer your question concisely, having a collaborative approach with orthopedic surgery, I think, is very important. And it works best if you already have an existing relationship with them.
Yeah.
Where they know that you've been in the trenches, you're there in the middle of the night, you're doing the stuff. That's how it works the best, I think.
Yeah. They've already got the experience of working with you on these cases, and so then when you're saying, let's do this new thing together, it's kind of, it makes sense.
Right.
Yeah.
Right.
Yeah. So one of the questions I ask everyone is about catchphrases, and I warned you about this, but I kind of always explain this as, the little cartoon angel that's sitting on your shoulder, whispering in your ear, telling you what to do. And, I've got Prosper Benheim and Cody Azari, Doug Sammer, Jeff Kenkel, maybe 20 other people who are kind of rotating cast of little cartoon angels on my shoulder. So what will the Harvard residents be hearing from the Kyle Eberlin voice in their ear?
Well, if you've asked them, I'd love to hear what they said. But I think one of the things that I say a lot, which is sort of trite but funny, is the bones are hard and white. And it sounds so trivial, but I try to keep things pretty simple, and surgery to some degree is pretty straightforward. Things are color-coded for you, so it lightens the mood a little bit. But if we're doing some, distal radius fracture or something like that, I'm like, guys, it's not that hard. The bones are hard and white. That's where it is. Let's fix them.
Yeah.
So that's definitely one of them. I'm not sure if they mentioned that, but
they didn't mention that one.
Oh, good. That's what.
Yeah. So that's a different one than the ones I heard. One of the ones I heard was if Plan A doesn't work, Plan B's got to be different, which I thought was a good one too.
Yeah, no, that's. We all have things that don't work, and you got to go back to the drawing board, and you got to come up with a different plan.
Yeah.
So that if Plan A doesn't work, Plan B must be different inherently from Plan A.
Right. Don't try the same thing and expect different results.
Correct.
How much? On that question of Plan A, Plan B, how much planning for Plan A and Plan B are you doing before you're going into these cases? Are you going in committed to one plan, or are you kind of thinking already about, hey, you know what, if this flap goes down, this is the next flap we're going to do, or this is the next salvage we're going to do, and how much of that are you consciously doing, or at this point it's like, listen, you've done enough of these that you kind of already know what Plan B is going to be?
Well, I think like any surgery with experience, you kind of have those things in your own mind, but I think it's most important to articulate that to the people with whom you are working. So early in the morning, before we go down and see the patient before a free flap or something, I'll have the residents come into my office, we'll look at the angiogram, and we'll talk through exactly the steps of the operation and the parts that are going to be challenging and the backup plans. And I think just having that discussion up front is so valuable. It helps me. I probably don't need to do that as much now as I did a few years ago, but I like doing it, and I know it's valuable educationally.
Yeah. It still clarifies things.
Yeah, for sure.
In everyone's minds.
Yeah.
Makes sense. And so, again, switching gears a little bit, but I've seen this in my own training, which is, I trained at UT Southwestern, and then I went to UCLA, and I saw, and even at UCLA, between the different surgeons there, I saw wildly different instruments being used by different kinds of people. And so I really like asking everyone this question, which is, if you could just have 3 or 4 instruments, and those are the instruments you're going to have to do the whole case, whatever the case may be, what are your instruments of choice? What's in your, little packet of instruments that you would just take with you on a desert island?
Yeah, well, if I get 4 choices,
sure,
I'll take an Adson forceps, anatomy scissors, Jake Schnitt, and a Freer elevator.
Oh, Jake Schnitt. Okay. Yeah. So that's what you like dissecting with that?
Yeah. Yeah. I do. Occasionally I'll use a McCabe, but I like the Jake Schnitt.
Why?
Because it's very fine and precise. It's relatively blunt. It's relatively long, so you can get really good tissue planes.
Yeah.
And it's somewhat forgiving, too, truthfully.
So you're not the kind of person who's doing a lot of dissection with the scissors. You're kind of doing more of the Jake.
I would say so, although I do like sharp dissection, particularly in the hand, using a knife. So if it's not sharp dissection, for a lot of perforator dissections, I'll use the Jake Schnitt.
Okay. Bovie versus bipolar. Are you the the people who do DIP flaps with the Bovie the whole way, doing the perforator dissection with the Bovie? Or are you kind of the more bipolar and?
Well, I'm very glad I don't do any breast reconstruction, so I don't do deep flaps. But
ALT,
No, I know. Just gave me the opportunity. No, as a self-respecting hand surgeon, I use the bipolar most of the time.
Okay.
But whatever's faster, truthfully.
Yeah.
And I think, actually, with regard to perforator dissection, if you see someone do it really efficiently, the bipolar stays in the hands, and you are going point A to point B directly. And I think that's something I think about a lot, actually.
Yeah. That's an interesting point, because I've noticed that as I have become more comfortable with perforator dissection, I get closer and closer to the perforator. Right? The first time I did one as a junior resident, I probably left like a centimeter cuff of muscle on the perforator in all directions because I was so scared.
Yeah.
It's actually more dangerous to do it that way because you can't see anything.
Right. It's sort of a paradox that it's better as well as easier if you're in the more dangerous place.
Right. At the same time, you're closer to danger, and you could more easy to screw something up. Yeah, it's a hard problem. Going back to the question of catchphrases, one of the things that one of the residents said was, you kind of always get on them where when they get to the point where everything's almost ready, right? The flap is maybe dissected, recipient vessels are almost ready, the only thing left to do is the micro, and there's always some futzing around at that point. It's like, I'm going to look at the vessels a little more and dissect them a little more, and you're like, just get to it.
Yeah.
And I've seen that too with residents, and sometimes with myself. What is it that's going on, do you think, in their heads? What's the hesitation, and how do they get past that?
Well, the phrase that I use, which may have been mentioned, is I say there's no microsurgical foreplay. Get the vessels ready and sew them together.
Right.
And I think that it's because, there's a lot of trepidation involved in making sure it's just right. But most of the time, if you have everything set up from a flap dissection perspective as well as the recipient vessels, if you know and they're set up properly, you don't need to mess around too much with them. So I think that part of the operation can take 45 minutes or longer for if somebody's doesn't know what they're doing. And if you're doing an ALT flap, sure, you got all the time in the world. But if you're doing a free functioning muscle transfer,
it's a clock.
I think you got an hour to get those vessels, to get the muscle viable.
Yeah. So. And do you think it's just fear, hesitation? What is it that's causing that?
I don't necessarily think it's fear. It's just not knowing or not having experience to just take the next step.
Yeah.
And I think when you watch someone transition, as you have, Puru, from a junior to a senior resident, some of the things that are most impactful is the decisiveness, where people learn to be the attending surgeon and learn how to kind of make those decisions. Because it's hard to make decisions if you don't really know, right?
And we're making a lot of them throughout the course of the surgery.
An infinite number during every operation almost.
And I always feel like that's actually the most fatiguing thing about surgery. It's not the actual doing, it's the fact that you're thinking, which is why if you're doing, a bunch of lumps and bumps, actually you might be working just as long, but it's not tiring because you're not making as many decisions.
Yeah. It's almost like golf. If you overthink your shot, you're not going to hit it well. Just hit the ball. Just do it.
Yeah. Everything's set up. You know you're set up.
Yeah,
that's fair. What would you say is like a simple surgery you do? I mean, you do a lot of complicated things. But what's a simple surgery you do that you see on your schedule and you're like, I like doing that surgery. This is great. It's going to be a nice day. We've got this nice, simple thing. At the same time, there's a lot of teaching there for residents.
Yeah, I mean, a couple of days a month I'll have an elective sort of hand peripheral nerve type day, and I really like those. They're outpatient surgeries. You can do quite a number of them. You're only in one place at a time.
Yeah.
So I would say a day mixed with, some carpal cubital tunnel decompression, some triggers, and some lower extremity nerve, I think, are days that are offer the opportunity to really teach and to, in between, you have time in between cases to go through things. So I really like those days.
Well, what are the things with a cubital tunnel? What are the things you feel that residents tend to fall into the same traps over and over? Because you see the same things over and over.
Yeah.
Every new batch of residents comes through, it's the same mistakes. So what are those repeating things that you see?
For the record, our residents don't make any mistakes. I'm not sure how it works at UT Southwestern, but
they're perfect.
Yeah, I know exactly. A cubital tunnel is an interesting phenomenon. We could talk for 2 hours about cubital tunnel syndrome, but I think a lot of it depends on the etiology of why their ulnar nerve is not happy or not working, and it could be compression, it could be mobility, and so I think from a decision-making standpoint, it's trying to articulate how do we decide intraoperatively what we think the problem is, and then doing the right operation for that particular patient. Because, of course, my practice is to try to do an in situ release.
Yeah.
And if I need to transpose, I'll do a subcutaneous transposition. I like the adipofascial flap that Mel Rosenwasser described. That's what I typically do for it.
Yeah.
So
I always worry about this kind of balance between having an enormous incision so that the assistant, can see what the resident is doing, and not having such a huge incision that is more than you need. I always find that a hard balance. Which side of that do you fall on?
Yeah, it's tricky. Particularly in nerve surgery, I think it's tricky because I remember when I was a very junior resident, Dr. Jim May, who used to be chief at MGH, used to say, "There's nothing you can do that I can't fix." Right. And that's generally true, but with nerve surgery, especially as someone who does a lot of nerve surgery and tells patients that I do a lot of nerve surgery, I do not want to have a nerve injury. And knock on wood, I've never had a major nerve injury. I don't plan on starting, but I'm really vigilant about it because that's the worst thing that you can do. It's almost unfixable. You can fix it, but it's never going to be the same.
Right, especially high ulnar nerve.
Yeah, it's a real problem. So, anyways, I there's a balance between training and everyone has to learn how to do things, but you also want to provide the best care for the patient. That I always think to myself, if the patient were watching this operation, would he or she be okay with what's happening?
Yeah.
So.
Yeah, that's a good way of looking at it. What do you think, if you've got a resident coming into your room for the first time, I don't know at what point they start working with you, third year, fourth year, whatever it is. What do you think are the three things that they should be thinking about, prepared for? What are the principles that they need to come into your room with?
That's a good question. I would say if I had to choose three, and you asked me, and I've actually never been asked this question, but I would say understanding the indications for the operation, understanding the anatomy, and being ready, if I drop dead in the operating room, to take it from start to finish.
Right.
That's the way that someone should be thinking about it, because you may not be able to do it perfectly, but you should know how to do the operation, and you have to figure it out if that happens. I hope it doesn't happen, but
you really hope. That's a good point. I mean, you're saying that they need to come in, and it shouldn't be like, oh, I'm going to see how he does it. It's, I know how he does it. I already know how to do the whole thing. I'm not saying I'm skilled at it, but I should at least be able to tell you how to do it.
Exactly, and the times, and thankfully this is very uncommon, but the times where someone shows up to surgery and they don't really understand the anatomy or the indications, I'm not going to let them do very much.
Right.
And I don't think I should let them do very much,
Yeah.
because that's a prerequisite to being an active participant in the operating room, I think.
So that's kind of an initial conversation you have with the resident. Say, hey, tell me what we're doing and why we're doing it. And if they have a good answer, then you're going to hand them the instrument.
I remember as a hand fellow with Dr. Jesse Jupiter at MGH, he would do complex distal radius malunions, and if I did not show up before surgery with the written plan that was on the board when he walked in the room, nothing. You get to do nothing.
Yeah.
So you learn very quickly.
To
have a pretty comprehensive plan.
Otherwise, you're going to be sitting there. A lot of free time on your hands. That was one of the things that one of your residents said too, which is they said you kind of have this attitude of, if you hesitate, then you're going to start losing some instruments. Like if there's a gap and they're not doing something, and you say, well, let me just show you. Well, then it's game over at that point.
I try really hard not to do that. And it's interesting because as one gets more experience in surgery, you get better, of course, as you should, but the skill differential between the attending surgeon and the resident grows as the attending surgeon gets better.
Right.
And so, especially with regard to efficiency, I want to do things quickly. I want to, finish my day, do research, go to the gym, see my family, whatever it is, right? So, and a lot of times I have to remove myself and do something else or do a different part of the case to let them sort of move along.
Because part of it is the struggle.
Yeah.
You kind of have to struggle to learn. At the same time, you don't want to struggle too much.
Right. It's hard to watch someone else struggle. It's hard to watch yourself struggle, but somebody
it's
else
much worse to watch somebody
Correct.
else. Yeah.
Correct.
When you're struggling, it's because it's difficult.
Yeah. Yeah, when you do a really difficult operation at the end, I usually turn to the residents and say, I made that look really hard. It shouldn't be that hard.
Right. Well, that comes back to the assessment, right, at the end of the surgery, and saying why was it hard, and kind of trying to figure it out.
Yeah, I did this was 2 or 3 weeks ago, I did a really difficult radial to axillary nerve transfer in a patient who had a really bad shoulder injury, and it was just really hard. There was so much scar. It was really hard to even find the axillary nerve. I had to go back up to the posterior cord of the plexus. It was a whole thing, but at the end, I allocated like 2.5 hours to the case. It took a little longer. It ruins the rest of the day and everything. So you got to be really reflective at that point, I think.
Actually, when I was a resident on oral surgery, I had this extremely enlightening experience where the attending, they were doing a complicated mandibular fracture and they were struggling. And the attending was in there doing it herself, and she was struggling. And I saw this very interesting thing, which she stepped back. In the middle of the case, she just stopped, and she was like, I'm just going to stop, and I'm going to think for 2 minutes, why is this hard? And she thought for 2 minutes, and then it was easy. And it was a very interesting thing to watch that in the middle of a case. And I was like, I think it's hard to do it because you're in the middle of, your mind is full of thoughts, and you're having difficulty and you're stressed. But I thought that was a great kind of teaching point for me about being thoughtful.
And I think you get more able to do that as you get a little more experience, because when you're starting out, you don't want to have that moment where everyone in the room is looking at you like, does this person know what they're doing, right? Yeah. But once you have some experience, it's good to do that, actually. And it's very strategic in many respects.
Yeah. The other thing I've heard many people say is that, when it comes to writing down your plan, I've heard people who are like experienced, they've been surgeons for 20 years and say, I still write down the plan. For certain kinds of surgeries, I'll still have the plan written down. So I talked to Tim Schaub, and he was like, yeah, when I'm doing a policization, I have the plan written down, and it's on the board because I don't want to get it wrong. So I thought that was interesting. Do you feel like there's certain surgeries where you say you need to put more thought into them, or you're extra prepared because that's just the level of preparation that surgery needs?
For sure. If you do a carpal tunnel release, you shouldn't have to think about it as a hand surgeon. You should think, but not think about it ahead of time. But if I'm doing a really complicated operation, on my drive into work, I'm literally doing the operation in my head on the way into work. And I think it's really important. Yeah. My steering wheel definitely knows how to do a free neurotized gracilis free flap.
Yeah, it's felt it many times.
Yes.
Yeah. Well, this has been written about a lot, right? Like the rehearsal, the mental rehearsal of going through any kind of complex thing is going to make the actual thing much easier because you've gone through it many times.
For sure.
We're close to being out of time. Are there other things that I should have asked you about that I haven't? Things that are important, things that you feel like any resident or junior faculty, anyone who is, still building their surgical style and technique needs to always have top of mind?
Yeah, I think to answer the question, I'm actually going to answer it in a non-clinical way, because we're all surgeons. Everyone's going to learn how to do surgery. There's a bell curve of surgery. Most people are going to be somewhere in the middle, and everyone's going to be a pretty good, safe surgeon and going to have good outcomes and some outcomes that he or she wishes were better. But I think it's about time management and thinking, about what do you do outside of surgery? Is it research? Is it, what are the things you like to do for fun? And having that balance in one's life, I think, is the most important, because we get so pigeonholed into, we're surgeons, and it encompasses a lot of our being because it's just such a intense occupation. But having the time to smell the roses, and whether it's family or friends, I think is really important. And, I do the best job I can at that. If my wife were sitting here, she may may say something different, but I think it's really, really critical.
Yeah. Basically, keeping balance between, or keeping your eye on the other things that are important, not just being a surgeon.
Yeah, and everyone's balance is different, right? You have people who rarely sleep, who are able to contribute a lot, and people who are on a different end of the spectrum. All of them are okay. Yeah. But it's finding who you are as a person and what drives you every day, I think, is important.
Yeah, that's fair. I'm always trying to find things that other surgeons do and looking at their technique, looking at their style, and saying, oh, I really like that. I really like the way you do that. Say, hey, you use Jake Schnitt. I really like that. I'm going to start trying that. Yeah. But you find that sometimes you cannot combine. I can't take your way of doing thing one and combine it with my way, because it doesn't work together. So are there things that you do where you say, you know what, if you're going to do this thing my way, you got to do it. You got to do all these things. You can't just do this one thing. So, hey, for example, if you're going to do the kinds of lower extremity free flaps that I do, you should be doing a CT angio because that's, or rather a formal angio. So are there things where you look at your entire system and you say, you got to take the whole system. You can't just take pieces of it.
Honestly, I'm not sure that is actually the case. I think there's a lot of art in what we do, clearly, as plastic surgeons, but there's not only one way to do things. And I love when somebody brings up a different way of doing something that's markedly better than the way I do it. And sometimes that happens with a young, very smart, innately intelligent medical student who's like, why are you doing it that way? Right. And you're like, well, it's just the way you do it. And then they say, well, what about this? And you're like, that is an amazing idea. Thank you for bringing it up. And that's going to save me time.
Right.
And so I think I'm always willing to try something new if it's better or if it's going to, make a hard part of the procedure better, like 100% of the time.
Yeah.
And that's actually one of the things with my residents and fellows at the end of the case. I'm like, what? Or even during a case, I should say, where I get to a part, I'll give you a clear example. So when I do a thoracic outlet decompression and I'm doing scalenectomies, it's actually hard to resect a lot of the scalene muscles because they retract a lot.
Sure.
And right before I do that part of the operation, I turn to the residents and fellows and I say, I'm about to make this look hard. I want you to really think about it and tell me how to do it better. And I've had a few suggestions that have made that part of the operation better. So I don't think there's one way to skin a cat is what I'm saying.
Yeah. What tell me about that, about the scalenes. What have you changed to make it better?
Well, I think that I like to take the scalene off of the clavicle and first rib, but I think if you just cut the scalene, it retracts a lot.
Yeah.
So I've devised a way to use snaps and hemostats to kind of hold the muscle so that I can resect as much as possible.
Right.
So I think that part has been helpful.
So instead of just going through it and then everything retracts, you're kind of like grabbing it, pulling it, and then
exactly
going through it in multiple,
Correct.
Maybe across a hemostat on both sides kind of thing.
That's right.
Take out chunk.
That's right.
Yeah, that makes sense.
That's right.
All right. Well, anything else you'd want to add?
No, I appreciate the opportunity to be here. It's interesting to have these discussions. Many of the questions I haven't thought about too much, but I enjoyed our discussion.
Well, thank you for being here. It was fantastic to talk to you, and hopefully the next time we meet, we can play some squash.
That'd be great. That'd be great. Thank you.